Hello, my name's Tim of 247nursetutors.com, and I want to welcome you to Cardiac Part 2. Have you ever taken care of a client who had angina? Angina is scary. Angina itself does not usually damage the heart, but it is a warning sign that could not be ignored. Angina is also called angina pectoris. It is a symptom of an underlying heart condition. It means that the heart is not getting enough oxygen. This results in chest pain, or angina. Stable angina occurs when the heart has to work harder than normal. It can occur during exercise. It has a regular pattern, and often patients become familiar with this pattern and are able to eventually predict it. Once they stop what causes the angina or take a medication, usually nitroglycerin, the angina stops. In unstable angina, there is no predictable pattern. It is considered more serious and may be a predisposition to myocardial infarction. It may occur at rest. Unstable angina may also quickly increase in severity or crescendo. This is a symptom of an impending heart attack. Can you tell me what the difference is between refractory, variant, and silent angina? Refractory angina is a type of angina that does not respond to medication. Now that is a mess, because we always want the patient to respond to treatment. Remember what I told you? When you see the word refractory, it means the patient is not responding to treatment. So when they are meant to get better, there is no change or they are getting worse. Variant angina is also known as Prinzmetal's angina. It often occurs while someone is resting at night or during normal sleeping hours. It has no predictable pattern and is not brought on by exercise or emotion. It is typically the result of a spasm in a coronary artery. Silent ischemia, the name alone says it all. Silent equals no symptoms. Silent ischemia is when there are EKG changes indicating ischemia. ST evaluation, but the patient exhibits no symptoms. We've discussed the major types of angina already. What's the difference between stable and unstable angina? That's right. Stable angina has a predictable pattern, while unstable does not. Which is likely more serious? Correct. Unstable angina is more likely to be a precursor to a myocardial infarction. Typical symptoms other than chest pain include dyspnea, tachycardia, palpitations, nausea and vomiting, fatigue, diaphoresis, pallor, and syncope. The common symptom is a pain, ache, discomfort, or tightness that a patient will describe as coming across the front of their chest, particularly on the exertion for stable angina. They may also, or just, feel the pain in their arms, jaw, neck, or stomach. Typical angina pain does not usually last long. It will usually ease within 10 minutes upon rest or with nitroglycerin. The pain will often go away with nitroglycerin after 1 or 2 minutes. Some patients may exhibit pain when bending or eating. If the symptoms are not typical, then it is sometimes difficult to tell the difference between angina and other causes of chest pain, such as a pulled muscle in the chest or even heartburn. Some patients will also become breathless when they exert themselves. Occasionally, this is the only symptom and there is no pain. Typically, other diagnostics are initiated to more specifically determine the cause of the pain. Have you ever done a 12-lead EKG? If you haven't, I highly recommend you try to get one done during clinicals or when you are a new grad on the floor. An EKG should be performed immediately on a patient with chest pain. During an angina attack, ST elevation or ST depression may be seen. What is an echocardiogram? An echocardiogram will show mechanical issues with the heart, such as a poor pump performance or valvular abnormalities. A stress test may be done to elicit angina and allow for evaluation of the ECG for ST changes. Stress tests are not usually done emergently and are not performed on patients with unstable angina. A change of at least 1.0 millimeters in the ST segment is considered a positive stress test. An elevation in CRP, or C-reactive protein, is an indication of inflammation and myocardial infarction. CRP elevates within 1 to 2 days and peaks at 3 days after an infarction. Ultimately, a cardiac cath or angiography may be done to specifically identify the vessel or vessels involved and the location of the blockage. The bottom line is to increase the oxygen supply and decrease the oxygen demand on the myocardium. This is done by oxygen via nasal cannula or face mask during the acute event. Bed rest is indicated during the acute event as well. A quiet environment should be maintained and sedatives may be used, and pain medications such as morphine or fentanyl may be used. The ECG should be monitored at all times. Nitroglycerin is a mainstay of therapy. This may be given in IV form for unstable angina or sublingually as a spray, topically, or PO for stable conditions. Beta blockers and calcium channel blockers are used to assist in reducing oxygen demand. Ultimately, a cardiologist will be consulted and a reperfusion strategy will be selected that is most appropriate for the patient. As mentioned previously, nitrates are a mainstay in the treatment of angina. Beta blockers reduce myocardial oxygen consumption by inhibiting the adrenergic effect of beta 1 and beta 2. Beta blockers prevent catecholamine release. These actions reduce heart rate, myocardial contractility, and blood pressure. This in turn reducing myocardial oxygen consumption. Calcium channel blockers block calcium movement into the cell. They also interfere with the slow channel current of sodium. They decrease blood pressure and systemic vascular resistance. This decreases afterload and causes coronary vasodilation. This improves oxygen delivery to the heart and decreases the workload of the heart. Nitroglycerin is a common drug used in most angina scenarios. Store at room temperature. Keep away from sun, humidity, moisture, and direct light. What is the maximum number of tablets usually given? 3. A very common side effect of nitroglycerin is a headache. I have often cared for patients, particularly those on IV nitroglycerin, who complained about the headache more than anything else. This is simply due to the vasodilation that occurs in the vessels supplying blood to the head and the brain. Because of vasodilation, patients should also have their blood pressure carefully monitored. Nitroglycerin should be stored at room temperature and out of direct sunlight in a dark container and should be replaced every 3 to 6 months for the sublingual variety. It may be taken up to 3 times at 5-minute intervals for chest pain. If chest pain does not subside, they should seek out more advanced treatment immediately. Nitroglycerin spray should be replaced every 2 years. Patients should be monitored for the same side effects for the spray as you would for the sublingual variety. What med is contraindicated in patients taking nitroglycerin? Sildenafil, also known as Viagra or Cialis. This medication causes a decrease in blood pressure. If taken with nitroglycerin, this can lead to a hypotensive crisis. Therefore, it is contraindicated. Always do your best to obtain a good medication history from your patient or their family. This is an excellent example where failure to do so can really lead to some trouble. This is the end of Cardiac Part 2. I know you're sad, but guess what? I'll be back for Cardiac Part 3. You will be successful.